are you?
Hello, I'm good. How are you?
I'm good. So, as you know, that NCPDB is releasing a resilience series. So, this interview is for that only, and I am Mushka Kothari. I'll be conducting this interview. Are you
All right.
comfortable with? So we can begin with you introducing yourself, your background,
Yes.
your biography.
So, my name is Aarti, and I am a person with thalassemia. I have worked with the NCPDP as NCPDP Javed Abidi Fellow, and I have worked in the healthcare sector. Healthcare was something that was very close to me from the very beginning of time because I have had a very close relationship with healthcare systems, healthcare institutions. When I saw the fellowship, it was a very spur of a moment thing. I saw it and I thought this is something I really want to do, research, advocacy, and it also came at a time when I was actually learning about disability as identity, disability as how it is a different form of normative body. I was studying all that in my literature class. I am also a master's in English literature. I am currently pursuing my PhD in English. Actually, it's in English and disability studies. I'm trying to navigate how illness narratives in English literature, disability memoirs, invisible illnesses memoirs can contribute to medical humanities or can contribute to the diagnosis and interventions or in the medical field. So that's what I am up to now, and yeah, that's about me.
So, Africa, that you are very close to healthcare sector from the start, right? And
Yeah,
you are doing your fellowship in that sector only, right?
yeah. Yeah, so healthcare is something I'm close to it because I had my whole life wrapped around it. So being a person with thalassemia, it takes a lot of medical intervention from the beginning of your life. It's blood transfusions, medical diagnosis, and regular follow-up checkups, tests, and other complication comorbidities uh, make you interact with healthcare system like doctors, nurses, or even healthcare admin professionals when something is not going right, blood bank professionals, people who do the cross matching of the blood, and all of it is very like that intervention was very constant. I used to get my blood transfused for like before when I was younger it was once a month. Now it's once in 15 days. So that intervention is very regular, and when you see healthcare institutions with such a close lens, you are able to see that there are so many gaps. I got my transfusions for the most part of my life at a government hospital because we were not able to afford like private blood transfusions, and the quality of cross match blood was also better in government hospitals because they had that kind of infrastructure. So I used to get my blood transfusion at RML, and I was able to see the huge gaps. Even if you're not a person with disability, to get into a healthcare structure in a government hospital is really difficult. Going through a casualty, then getting your form signed, then getting your form filled for an admission, you have to go through a whole day process. There are no beds for people. Like as we saw in COVID, in actuality also, even if it's not COVID, there's a dearth of beds, medicines, equipment in general
Hospitals.
in government hospitals because we have a huge set of people we have to cater to, and we don't have the exact like matching resources. The number of doctors don't match, and then when we talk about disability, most staff doesn't have sensitization on how to cater people with disabilities, how to talk to them, how to, if you're diagnosed with thalassemia, how do you counsel parents them
Because they are not aware themselves.
yeah, so even if they know about the medical aspect of it, they don't know the psychosocial aspect of it or the attitudinal aspect of it, what barriers you might have to face instead of healthcare. That awareness, that holistic awareness was never there. And that is something I also experienced throughout because uh, when you are a person with a medical illness, like if you're a person with a chronic illness or a medical disability, to say that needs constant medical intervention, then it becomes that your life may the health is the most important part. Everything else that comes is secondary. So you just are told to be like told to survive. Other aspects of your life are not even taken care of. And even the healthcare aspect, I thought that is the primary aspect. So I am a person who's 25 years old. I am able to like do my masters, do my PhD because my health was managed somehow. Yeah, there were issues, there are issues that keep coming up, but I had the resources, I had the support from my family that I was able to get the medical intervention on time. And I live in a capital, there were resources like near to the capital where resources are available. But people who are living in remote areas, they don't even have the diagnostic facilities. Awareness is even less. People are not able to diagnose hyalocemia, they don't know what it is. They just go to if you see symptoms crippling up, they go to superstitious cures that are available. So, wo issue I have seen very closely. I know a lot of people, like when you go to hospitals, you get to know a lot of people who are suffering from the same disorder, who have the same disorder. And you realize that even though they don't have the awareness on how to manage it, because that education is not being provided by the healthcare professionals. And that is why health was never, it was never a question. Health was always something I wanted to work on. And other than even like, I have felt that there are two things that are most important in a person's life, that's health and education. If you have these two things, you will be able to achieve other things. I also feel that it's a state's responsibility to provide these two things. These two things should be the basic things that should be provided to people. Everyone should have the access to like equitable access to healthcare. People who are ridden in poverty, people who like disabled individuals who are usually under the who are usually not economically very well off, as we have seen in the studies, and other marginalized communities. Everyone, like if you are a person who comes from a marginalized community, your access to healthcare gets eclipsed, I'd say. So yeah, that's why health was never, it was never a question. I always wanted to work on it since the beginning of time.
Always clear about the sector.
Yeah.
Can you elaborate on the work that you did in the fellowship? What
Yeah,
steps?
so that was something that I had to narrow down because you want to work on health. But you are an individual with limited resources. You cannot do everything, you cannot fix the system. And I think even I got a lot of suggestions from NCBDP, and I think Sumit sir was always there, who used to keep saying that you have to narrow down your research, you have to narrow down your research, you can't work on everything. And that was really helpful because it puts things in perspective that, yeah, you have to choose an area, you have to work in that
In a
area
particular
perfectly.
area extensively.
Yeah. So it took a lot of time to me, and I worked with Vishwas. There was a person, there were two people who helped me. One was Rohit, who used to work in Vishwas. He works in Azim Premji now. And one was Pawan. He used to work in Vishwas as well. Vishwas was my partnering organization. So these two people helped me understand the landscape. I was working in Gurgaon because Gurgaon was most accessible to me. So these people made me understand the landscape, that what are the major gaps. If you go to the semi-urban rural community, what are the major gaps? What is the major gap that is coming in intervention of healthcare? And I realized that the major gap, because at the very beginning, is the diagnosis only. Most people are not able to get a diagnosis on time. Either it's delayed, that aggravates the disability, or either it doesn't happen. And now that also had many facets, that people don't have the resources. They spend a whole day in hospital to get a diagnosis. Because if they do that, they don't have their daily wage workers. They don't have food at night to eat. So how do you get diagnosis? How do you spend so much time and money to get that diagnosis? Because even if you go to a public hospital where facilities is free, there's transportation cost that takes, because public hospitals are not very near to the semi-urban rural communities, and diagnosis doesn't happen in every hospital. So you have to go, there's a transportation cost, there's medical cost, and just the whole day is spent, because it takes time. If there's a lot of crowd that goes to a public hospital, so it takes time. There's a lot of monetary issue that comes up, and people who are not, again, people who are daily wage laborers, people who work on per hour basis in Gurgaon, they don't have the privilege to go to a hospital regularly and get a diagnosis on time, or get a treatment that is like intervened regularly. So how do you cater to that? So that's how we identify the gap. We did a lot of field visits to identify this gap. I went to Jharsa, I went to Sona, I went to Tikri, the small villages and sects that we have
What
in
extensive
Gurgaon.
field research है.
Yeah, we did a lot of field work. I used to go to Vishwas, and then Vishwas helped me a lot in field work because they used to take me to the fields.
Okay.
They had their community rehabilitation program, so they used to do their community rehabilitation work, and I used to do the research.
So when you focused on diagnosis area, so did you focused on specifically diagnosis in the disability criteria or disabilities?
Nahi. So what we did was, again, we had to limit our scope of work. So what we did was, we took 21 disabilities only, and we tried to assess. We made a questionnaire with people of Vishwas. We made a questionnaire. We made an assessment. क्या कहते हैं, assessment questionnaire. So all we made a good questionnaire out of it, and we did a baseline study that how many people are able to understand the importance of diagnosis, how many people are able to afford a regular medical intervention in those community. Yeah, and how many people are willing to like accept a disability, because there's a lot of issue in community a disability as well. Even if they get diagnosed, they won't accept that it is a disability, and they won't get a regular treatment. They would rather go to like some baba. They'll try to not accept it. Even people who had the diagnosis were not ready to accept that it's a disability, or it needs regular medical intervention, or you need to get a disability certificate, because they thought that disability is something of a curse. If you accept it, you will be participating in the fact that your son or your daughter has that curse or has that problem, and now their life is doomed. That was the most the mindset that I found in Haryana. That was very prevalent. So I think the diagnosis again was a huge issue, because I met a person who had sickle cell, and she was not officially diagnosed as a sickle cell patient, because again their parents were like, "Ma'am, we don't have the money to go every day to the hospital." So we thought, the intervention that we thought would be necessary is to train ASHA workers around early intervention, early identification of disabilities.
So you chose 21 disabilities for that, as you mentioned.
Yes, we worked on all 21 disabilities, but majorly through the research, what we found is diagnosis delay usually happens in blood disorders. Diagnosis delay happens in cerebral palsy. Diagnosis delay happens in visual impairment, low vision. That is where it happens. Locomotor usually is very prevalent, so people are able to identify it earlier. So we did this intervention. We started this intervention with Vishwas. We used to get a resource person who was a medical professional, and he used to give lectures, like a small session on early identification of symptoms. Like अभी रिसेंटली एक आशा आंगनवाड़ी का मैनुअल भी आया है, तो वैसे ही हमने एक आईसी मटेरियल बनाया था, जिसमें हमने सिम्टम्स ले आउट करे थे कि अगर आपको ये सिम्टम है, क्योंकि आशा वर्कर्स का ना फर्स्ट कॉन्टैक्ट होता है बच्चों के साथ इन कम्युनिटीज में. देयर इज अ प्रोग्राम दैट इज द मदर एंड चाइल्ड केयर प्रोग्राम. तो इस प्रोग्राम के थ्रू दे इंटरवीन रेगुलरली विद pregnant women, and then when the child is born, they look over their developmental milestone. तो हमने उनको ये पूरा आईसी मटेरियल पढ़ाया, समझाया कि अगर आपको कोई भी ये सिम्टम दिखता है, आप उन्हें रेफर करें अपने प्राइमरी हेल्थ केयर सेंटर में.
Then after training them, आप लोगों ने follow up करा?
We tried to, but honestly, that was a very challenging task for us, because firstly, it is very difficult to get the same set of people in a session, even in the same geographical area. Everyone who came earlier will come. Every time you will see a new set of people comes. Yes, there will be repetition, but mostly a lot of new faces will come, and then you have to do the whole session again. And that happens because there is no regular standardized employee role of ASHA workers. They are also overworked, overburdened, and they are not very well compensated for the work they do. So the question is, ma'am, why do we do that? We are not getting compensated for this. And then it becomes, when you go as a civil society, the one thing that becomes challenging is कि सरकार से तो ऑर्डर नहीं आया, हमारे को तो बस इतना ऑर्डर है कि डिसेबिलिटी सर्टिफिकेट So convincing was a problem. But yeah, we did do a couple of feedback sessions with people, and there were a few people who came back again and who responded to it. And actually, there was the retention rate of the people who came was good. Like, women were sharp enough to remember everything that was told to them even 3 or 4 months before. So if that program actually happens on a very administrative scale, it has a lot of potential. Healthcare is something I've been very interested in since beginning. Healthcare, I at one point in very young age, I also wanted to be the doctor, but then I think I got very inclined to literature later. But healthcare is something that has been close to me because, again, when you see a system from very closely, as a thalassemia person, now I am aware of my disorder. I would say, if not more, but equal to a lot of doctors who are still in the learning stage of the disorder. I don't think healthcare intervention so closely देखना choice थी. It was something that happened and I was interested in it because when you are going through it life, you are going through it in life, you get interested in it. So, firstly, thalassemia was not part of the Disability Act till 2016. It got into the Disability Act in 2016, and I think I got into my college admissions in 2017. So that's where I I was able to get that reservation and I was able to get into a college in Delhi University. When I was doing literary studies course, I was reading a lot about like their English literature offers a course on disability studies as well in your masters. There's a course on you take your other subjects where you study psychology and philosophy of the normative body, what is normal, what is abnormal. That this is something I was reading a lot, and I think that was the stage that helped me understand disability as identity, like more than something that is more than medical, something that transcends the medical and transcends to life.
Yeah, it comes around in a social psychological realm also.
Yes, because then I started to realize that probably if it wouldn't have been for thalassemia, I would not have been interested in how health system work, or I would not have had the knowledge of like the knowledge of the body I have now. So your disability makes you the person you are. I'm able to empathize with people with illness more, I think, because I know how it feels to have a chronic illness. So like there was a movie I saw actually. It's called Ship of Theseus, and that in that movie there is a person who is blind, but they are a photographer, and they take amazing pictures even though they can't see. They just feel the sound and they take pictures, and then they are due for an eye surgery to get new eyes. And after the surgery, she regains her sight and everything, but she cannot take as good pictures as she took when she was not able to see things. And that I think that was a turning point, and I realized that probably your illness, your disability, anything, it makes you the person you are. I'm not saying that my life did not have issues with the disability. Yeah, there were so many issues, but it's still it's still who you are. You have to accept that it's part of you. You have to
Yeah.
acknowledge it. You have to wear it on your sleeve and just go around the world with. But again, I realize that I have the privilege to accept it, because when you have a medical disability like thalassemia, it can be very challenging if you don't have the resources. Like if you don't have, I take 15 capsules a day, and that medicine is expensive. So my medication per month costs more than like 6K, 7K. A lot of people are not able to afford it. And if they're not able to afford it, their body gets affected very badly. They don't have the privilege to romanticize it, I think. You are able to accept it, but you need to be like, it's the responsibility of the state, it's the responsibility of the administration to provide people the aids, the facilities, the medical facilities, so that they're able to live their life fully. Because if you have the resources to get your medication on time, if you have to get your blood transfusion on time, it will not cost, like you can have a fully fledged normative life. It will not be an issue. But again, that is very scarce. That is very rare.
We really need to work on the administration.
Yeah, that is true. I mean, I think that the key is to provide the basic, because healthcare is as basic as it could be. If we can't keep our population healthy, what are we even doing?
So when you were working with the administration, the primary healthcare, as you said, तो आपका experience कैसा रहा है? Because our administration is very rigid. It has been so many years. Disabilities बढ़ नहीं रहे हैं. They are not, categorizing more and more problems as disabilities, which are actual disabilities. So how was your experience there?
Yeah, I mean, to me, too, the problem is that you follow the UNCRPD definition that any impairment is a disability, but then you come up with the schedule that only these 21 qualify as disability. So it's self contradictory. Then how can any impairment be disability? Like any health or physical impairment or mental impairment is defined as a disability in UNCRPD. That is like it should be a long term impairment. But then our country follows that definition, and then our country also gives you that only these 21 impairments count though. So that is a self contradictory document there. But local administration, my experience was mixed. It was not that bad. A lot of people were very upcoming, especially at the higher end. Like I talked to the deputy commissioner, the SDM. They were actually willing to, like, they were willing to learn. They were willing to understand the aspect. Okay, tell us what the problem is. Let's see what we can do about it. That's true. The wheels of the administration work very slowly. So even to get arrange a first Asha session that we did took us 3 months, because and we have to go again and again, and that was, and I was told that was a quick turnaround, that like we did it quickly. 3 months is not a huge like time. I think the problem I faced a lot was at PHC level, primary healthcare level, where doctors were there. PHC doctors, some of them were very good. They had the awareness, they wanted to give an interview, but some were not into it. Some, like, again, the problem is why are you doing a survey? Why should we give you an answer? Why should we give you the data? That is a problem. The other problem was the lack of awareness on disability. I mean, a lot of people did not even know that, okay, thalassemia and sickle cell is something of a disability. And then what is the procedure if you, like, what is the procedure to refer a person into a civil hospital? Disability diagnosis doesn't happen in the PHCs. You have to refer. But referral system is complicated. So these are the gaps that I felt. Yeah, assessment बहुत बड़ा issue था I think लोगों के लिए, like assessment for certification, because doctors available नहीं है certification के लिए. गुड़गांव में 2 दिन होता है certification in a week, and in 2 दिन में hematologists come at one day, and a lot of time they are not here because again we don't have enough hematologists to diagnose for blood disorders. We don't have enough psychiatrists to diagnose autism or diagnose any other mental health condition. We don't have enough urologists. So that assessment becomes a huge challenge. Even if you're diagnosed, even if you go to a private hospital, you get diagnosed, and you have the diagnosis that you have a disability. To get a certificate, you have to go through the whole assessment and diagnosis phase again at a government hospital, because certificate the government hospital provides the name. And वहाँ पे there's an issue of doctors available नहीं है. Even I had to go 3 to 4 times to get my certificate because the doctor was not there. It's because there's a lack of doctors, huge lack of doctors. So that is the issue.
So when you went to the DM and the STM, as you said, and they were willing to learn about the disability, how did you feel at that time?
So my feeling was that is good that they are into it, but it's not enough.
Yeah.
I feel you giving a go ahead is great, but you need to actively provide resources to people who are willing to work. Because as a person, if I am organizing a training session, it takes so much resource to develop a training, and we also want, like, they gave us a go ahead on okay, go do the training sessions, and we will ask ANMs to help you to get the numbers. So that, I think that was very helpful, and that was something I felt very grateful for, that we were able to get good numbers of people, we were able to train good numbers. That was a helpful. But I still think that resource allocation in the disability sector, especially monetary resource allocation in the disability sector, is important. I'm not saying that the disability monetary allocation should happen to me, it should even happen administratively. This training program should be an administrative program.
Yeah.
Yeah.
So when you
So
saw
yeah.
कि resources नहीं है, as you said, or the you are trying to sensitize doctors about it at the primary healthcare centers, but they're not willing to learn. I don't know, मतलब, you are not able to help another person just because somebody does not want to learn. What did you feel at that time?
So the the doctor thing is, so what happens when you go to talk to doctors? There comes a power hierarchy that you can't teach me this. I have
I'm the
learned this.
doctor.
I'm a doctor. So this even happens if you like, if I'm a person with thalassemia, if I go to a doctor and I tell him that these are my symptoms, sometimes the doctor is that nahi, this is not anything. There is nothing to worry. You just take this. I'm telling no, I have experienced this before. There is something to worry. So, and if they are not hearing it, because there is a power hierarchy between a patient and doctor, but I know more than you. Yeah, so there is this attitude even in that was one of the challenge, because you have to tell people that this is the issue that we are facing in the healthcare sector, and this is diagnosis is not happening. What is the referral system? So you are asking a person a lot of questions about their profession. So it feels like, I think it feels very challenging to them also. Ki you can't come and ask me that. I know better than you. I have studied it. I have given my life to it. So I think that was the issue that we faced. But yeah, some people were very good. There were some PHCs where actually they maintained a whole data on अच्छा इतना diagnosis हुआ है in this month. These many people are people with disabilities. These many people are come from SC community. They come from ST community. So they had the whole data, because that's what they are asked to maintain as a community healthcare center. All this data, they were very well maintained, and I noticed that people who had everything in place, they were more willing to talk and like, yeah, let's talk about it. Yeah. And they were more willing to give us an interview,
Okay, so
because
that's
they have
great.
everything in place already. So that was good. And infrastructurally, PHCs are not well designed for people with disabilities. That is something also what we faced. Centers accessible nahi hai, because PHCs are built in, like, government rents some houses and builds a PHC in that, so they're not accessible. There are stairs. Sometimes there is no light, so it's pitch dark in a PHC. So that was an issue. Infrastructurally, there was a huge issue of accessibility. There's a wheelchair at a PHC, but there's no place for a wheelchair to move around because it's so congested.
What motivated you to stay on that
I
position?
I think there were times when I was not motivated. I also was not able to work for a couple of months, because I was like, this is not going anywhere. Where is this going? Because it gets very difficult for you to just keep chasing the one thing again and again
Yeah.
and again. And I am a person who was very new to the sector. NCPDP was my first eye opener towards the sector. I don't know anything about advocacy when I'm going in talking to people. I don't know anything about how do you reach the people, how do you reach out to administrative people, how do you reach out to other activists who are working. I was very new to it. So I think for me, advocacy part was a bit challenging. Research I had experience with. During my masters, I was able to learn that kind of a skill on how to conduct the research. I did my master's in literature, and this was social sciences, so I had to learn a couple of things here and there. But yeah, research part I enjoyed more than the advocacy part, because advocacy part was a bit challenging, as I told you. I think what motivated me was when I used to go to the field and I used to collect the narratives of people. I used to talk to people and they used to come forward and say, "Ki, we're not able to do anything. We are just helpless at times." I was like, I just have to keep doing it for them and for me to come back to these stories. I realized that it's the first person narrative that often goes missing in all the research and
Yeah.
all the advocacy. These people who have very, very real stories, very, very real challenges,
Genuine stories
they
and
just
real life
become
experience.
numbers.
Yeah.
Yeah, they just become numbers in research, that one person was not diagnosed, 2%. But that diagnosis that did not happen has a whole story, has a whole reason, has a
Yeah.
whole set of challenges. that is what motivated me, and that's still like I think narratives are the basis of everything, and that I still work towards it. Like we opened our own platform that talks about invisible disabilities and their narratives, how their narratives, what are the challenges of people with invisible disabilities that are not apparent, or that are hidden. Because yeah, so that is one
Because
thing that,
narratives give in-depth details, basically.
yeah, and that's why I was very adamant on doing a qualitative research, because
Yeah.
is I didn't want it to be a numbered study or a statistical analysis, because I felt qualitative research will have probably the numbers will be less, but the data that comes in will be in-depth data, will give us a holistic sense of the issues that a person is facing. Through, like, even if it is one challenge, the issues across that challenge gets presented more holistically in a qualitative research.
Yeah.
So yeah.
So when you were facing those months where you couldn't work or you were tired or burnt out, what was your support system?
Uh, I think there were a lot of phases when I was there was either home there was some issue at home, or there was some issue with my health, or I was just not mentally well at times. I was also diagnosed with ADHD in between, so that happened. But I think the support system was family and friends. And I think that my family, my parents, and my brother, my sister in law, they have all been amazing since the very beginning. And I think I've been able to achieve anything like in my life, because there was there was no anchor in my life that was holding me back. Like, they've been supportive. Okay, you do your thing. It's like the disability has never been a problem for my immediate family, as per se, for me to, like, okay, you have this medical issue, you should not do this, you should not do that. Yeah, I mean, they are overprotective at times. They also deal with their own set of issues. Oh, you will be able to go out and stay 10 days outside of home. But now, like, that those things don't come up that often. Pehle it used to, because they were used to getting used to the idea of my independence, because I have
It's
been very dependent on my parents for a lot of healthcare support. So it was tough for them to let go of it. But yeah, I think family has been a good support system. Friends have been a great support system. I got some great friends in college, at university, and I have like 5 girls who listen to my rants, who listen to all my emotional mental crisis. So
I
yeah,
know
that was there.
that must be good, right?
Yeah.
So what did you learn in NCPDB fellowship?
Oh, a lot of things. Again, I had no idea about disability sector before entering. I had no idea of. I was so new when we went to the induction. I was so new that I didn't even know. Acha, these are the types of barriers that exist. This is how we talk in the community. The idea of disability existing this due to the atmosphere around you and not within you, that came from NCPDP. So much learning around NCPDP. Say I got a lot of opportunities to present my work on conferences, consultations. I was a terrible public speaker before this, especially during college school. I mean, not terrible, but I had used to have the staging, the anxiety and fear. I think that it helped with that also, because I was so sure that of the work I was doing. I was so happy in the work I was doing that I was able to talk about it very confidently. That yeah, I am doing, if not great, I am doing a decent work, and I should talk about it. So a lot of things. NCPDP helped me. It was an eye opener of fellowship for me. In Yeah, I did not have the disability perspective I have today. I met a lot of great people. All the fellows are amazing, amazing, amazing people. Everyone at NCPDP is amazing. From Arman sir, Ujjwal, Sumit sir.
So
Yeah.
how did it evolve you as a person? Your whole journey studying about the medical issues and working towards it, and how did it evolve you as a person?
I think as a person, so the thing is, like, I knew about disability. I knew about, okay, there is this thing that exists, but it was a distant thing. Thalassemia, it was not a distant thing, but I have only been around the community of people who have thalassemia. So I remember my first day of the induction when I went, like there's the induction that happened in Delhi. That's how the program started, and I met all 25 fellows. It was so diverse. We had people from all 21 disabilities. And again, when I spent time with these people, I learned, okay, there's so much to learn about it. I know nothing. And I think that's when the journey started of learning. The fellowship has been a journey of learnings and unlearnings. I had to unlearn a lot of things, a lot of perceptions, a lot of presumptions that was there. That had to go out, learn new things. But as a person, I feel the fellowship made me a more confident person, a more comfortable person in my identity, and a person who has more self belief than I had before. That okay, yeah, I can do things. Because I have been a person who has been riddled with self doubt. That happens even today. Self doubt is something constant, but yeah, it happens less often than it used to happen. Yeah, it has changed. It has made me a more empathetic person, I think. I got to learn so much about so many conditions. Yes. So I think it inculcates empathy because when in a fellowship setup, you just don't learn it. You just don't learn disability. You live with people. Like if
Yeah.
it's a week long induction program, you live with them, you talk to them, you have fun with them, you crack jokes with them, and then it becomes like it gets normalized. Everything gets normalized. Yeah, it makes me more aware, more empathetic. Yeah, that's that. I think that was the experience. I made such good friends across sector, across disabilities, and so much got normalized. That okay, uh, so then not even in terms of disability, even in terms of geography,
Yeah.
like people came from all across the country, and so much got changed. Oh, I thought that in your state this happens, but it's not like that. You you learn that people are just very same all across. They have the same human struggles as you do.
So, what are your future plans?
Future plans hold me a lot of dilemma, but my first future plan would be to get done with my PhD. Hope that I am able to do it soon. Huge journey. I think that's also very taxing. Keeps on like PhD is something that uh, keeps on dragging, and you just don't know when to end it, how to end it. But I think the first plan will be to get done with the PhD. I really want to work in the field that is emerging, graphic medicine, medical humanities. I want to develop it, like it's a pretty ambitious future plan, but I want to develop a theoretical framework on how illness narratives can help medicine. So that is something I'm working on. And other than that, I really enjoy interacting with people. That's also one thing I learned through the fellowship somehow. That it's one of my favorite jobs to interact with people, talk to people, talk about the things I like, things I want, academic things. So I see my future in academia as well. I would like to teach people. I have also taught a couple of university students. I used to teach at Shahid Bhagat Singh SOL students literature, and I think I really enjoyed that. It was a very rewarding experience. So I think my future will be to like the aspiration will be to teach disability studies or literary studies to people, and could be like very difficult to crack in Indian academia. But let's see how it goes. If not, definitely research, not weaving. Research is something that will be constant in my life. I really enjoy it. Yeah.
Thank you so much, Aarti. It was really nice interacting with you. Actually, it was very informative. I didn't know about, I know the 21 types of disabilities have, but I didn't know that it was, changed in 2016. Yeah,
Before 2016, there were only seven. Yeah, so a lot of disabilities got added in the schedule.
that's quite
But yeah,
achievement.
that's the process. Talking leads to learning.
Yeah. Thank you so much for
Yeah.
interacting with us.